operative scenario on tracheostomy and maybe the tracheostomy and its complications also. Dr. Aditi is a second year junior resident at Howrah District Hospital, and today with us will be Professor Ujjwal Kumar Bhattacharya, who is a professor and head of surgery at Calcutta National Medical College. So, Dr. Bhattacharya, you can start.
Dr. Okay,
Yeah.
Dr. Aditi. Hello. And the first, how will you, what is your understanding? What is basically what is a tracheostomy? Hello.
Yes, sir.
Hello.
Hello, sir. Am I audible, sir? Hello?
Yeah.
Yes, you are now audible.
Yes, sir. So, tracheostomy means creating an external opening in the trachea for ventilation, which could
So
be
that you can
elective or
have a
emergency.
direct access to the air passes through the trachea.
Yes.
That's okay. Okay. So that is the basic thing regarding the terminology of tracheostomy. Now, if I ask you that we just want to divide the two terms, so one is tracheotomy and another is tracheostomy. Can you just differentiate between these two terms?
So, tracheotomy means creating an external opening in the trachea. In tracheostomy, we create a stoma which connects to the trachea internally through the tube.
Can you give us some better understanding regarding the difference between the two? Tracheotomy, certainly you are gaining access to the trachea, but you are not making a mature stoma with the trachea and the skin. But whenever you are doing a tracheostomy, that means, yes, you have done a tracheostomy, along with you are fixing or maturing the opening of the trachea along with the skin so that the tracheotomy becomes a tracheostomy. Okay. So basically, in loose terms, we call it a tracheostomy, whatever may be the type. Okay. So now, hello, can you tell me what are the different settings or what are the different forms of tracheostomy, different settings of tracheostomy?
So it could be elective or emergency tracheostomy.
So one is, yes, elective tracheostomy. Okay, done. One is emergency setup tracheostomy. Okay, so that is the second setting. And
it could be permanent or temporary.
Permanent tracheostomy or a temporary tracheostomy. So there is another form, rather basically nowadays gaining popularity in the ITU setup. Okay, what is that procedure?
Bedside intubation.
Minimally invasive form. Yes, sir. What is that? Percutaneous dilatation tracheostomy. So these are the three different settings. One, you are in the non-emergency setup, open, planned tracheostomy. Another is in the emergency setup, that is the emergency tracheostomy. And the third one, sometimes you do require for a tracheostomy in the ITU or say in the surgical ward in SICU. So the minimally invasive form of it is percutaneous dilatational tracheostomy. So these are now okay. Now, can we come to the different indications of doing tracheostomy?
So there can be mechanical obstruction to the airway, like foreign body impaction or acute laryngeal edema.
Just before that, again, indications, different setups, different basic headings of doing the tracheostomy. So that you are saying the ingestion of foreign body leading to an acute choking. That means acute obstruction. Setup is acute obstruction of the upper respiratory passageway. Okay.
Yes,
So under this heading, it will come, yes, foreign body occlusion.
or sir, in case of neck trauma, if there is a tracheal or a laryngeal injury, we are suspecting.
Sure. Yes.
In case
Go
of the
on.
bilateral recurrent laryngeal nerve palsy,
Yes. Yes.
sir, acute laryngeal edema we can do. Then
Acute laryngeal edema, inhalation burns,
inhalational burn
sometimes.
injury. Then to aspirate thick secretions.
Oh. Yes, yes. So getting access to the lower respiratory tract, taking care of the lower respiratory tract, sometimes following a heavy ingestion, heavy aspiration, na? So as to reach the lower respiratory tract and clearing the lower respiratory tract. So basically, what are the basic indications whenever you have acute choking or acute obstruction of the upper respiratory passage? This is one. Second one is the impending obstruction that you are anticipating that there will be an acute obstruction very shortly. So that is another one. And thirdly is that you are taking care of the distal respiratory tract, say in the form of healthiness of the distal respiratory airway. And the fourth is that you have not yet mentioned, that whenever a prolonged ventilatory support is necessary, this is commonly you see in the surgical wards. This is also very important. Whenever there is a prolonged ventilatory support is necessary, we do proceed for a tracheostomy. So yeah, yes, you have mentioned the different reasons under these four headings. Okay, under these four headings. Now, coming on to the prolonged ventilatory support tracheostomy. Okay, so in this case, usually how many days we do continue with the laryngotracheal intubation? After that, we consider the tracheostomy. What is usually the time period? Hello.
Yes, sir.
So it is. Hello.
Yes, sir.
Dr. Saha. Yes. Dr. Saha, if you want to comment.
Yes. Yeah. When you get a referral from ITU saying that this patient needs to be now tracheostomized, usually what is the time gap from intubation to requirement for tracheostomy?
Intubation to tracheostomy. So this is usually 10 to, the window is between 10 to 14 days. 10 to 14 days. So, why do you consider a tracheostomy in a patient of prolonged laryngotracheal intubation where it is to be continued, ventilatory support? Why do you consider that? Doing a tracheostomy?
So to relieve, to support the ventilation so that the external efforts of patient respiratory muscle decreases.
So this can be one reason, but this is not the primary reason.
What is the difficulty of what is the difficulty of prolonged intubation, endotracheal intubation? That is true. What larynx?
So larynx. What happens to the larynx? Yes.
Laryngeal, in case of prolonged intubation, larynx becomes dependent for external.
This is the more you are keeping the laryngotracheal tube intubation, the more will be injury to the larynx. So subsequently, whenever the patient comes up with a prolonged intubation through larynx, laryngeal injury itself might result in some severe problems in the form of laryngeal non-functioning, laryngeal stenosis, etc., etc. So we do not want to prolong laryngotracheal intubation for more than 10 to 14 days. So this is usually the normal period. But sometimes we may need to do an earlier tracheostomy rather than the window of 10 to 14 days. And sometimes we may prolong for, we may consider after 15 days or 20 days, something like that. What are these situations? What is the difference?
In case of if we are
In an
suspecting
intubated patient. So normal window is 10 to 14 days, but sometimes we may need to do at an earlier period, and sometimes we may do it at a later period. What is the consideration in both the situations? It is said that if the patient is extremely restless, that means the patient is not even wanting to have the tracheostomy tube. So there is gross movement of the, laryngotracheal tube. So that is causing a mechanical irritation, mechanical injury to the larynx. So at that situation, we may have to consider a tracheostomy earlier than the window period of 10 to 14 days. On the other hand, if a patient is deeply unconscious, so that there is no movement on the part of the patient, so in that situation, that is not going to injure the larynx early. In that situation, after we may consider doing a tracheostomy later, after the window period of 10 to 14 days. So this is the basic individual situations, considerations where we may have to do a tracheostomy. Okay.
Okay.
So Dr. Aditi, yes, Dr. Shah, yes, yes.
Yeah. Another indication is when the patient has got profuse secretion.
Yes,
if the patient has tracheobronchial secretion, it is easier to aspirate the secretion through the tracheostomy rather than the endotracheal tube.
Yes. Yes. So, Dr. Shah, can we pass now on to the operative procedures?
Yes. So, and another point of about permanent tracheostomy. Name a situation where we need to have a permanent tracheostomy.
So in case of thyroid cancer.
In case of
thyroid cancer.
More commonly, it's a following laryngectomy. If you have a single following, it's a permanent tracheostomy. In thyroid,
yes,
it's a palliation.
Yes. So can we now go on to the operative procedure now, Dr. Shah?
Yes.
Operative procedure.
Yeah.
So, Dr. Aditi, now can we pass on to an emergency tracheostomy procedure, open emergency tracheostomy procedure? Now, can you tell us what should be the technique?
So the patient will lie supine with neck extended with using head ring and sandbag. We will do the antiseptic dressing and local anesthetic infiltration, and then for
you are doing an emergency tracheostomy. So yes, local infiltration. Sometimes you may not require even a local infiltration because this is so urgent that the patient is deep and say comatose. Okay. Say a head injury, maxillofacial injury, patient is deeply comatose and you need an emergency tracheostomy. You may not even need to proceed for a local infiltration. Nah? Yes.
Then we will palpate the cricothyroid membrane and make a transverse incision of vertical. But in emergency setting,
you will not choose a transverse incision whenever you are proceeding for an emergency tracheostomy. So it is a vertical incision. What should be your activity with the non-dominant hand? What would you do with the non-dominant hand?
So with the non-dominant hand, thumb and middle finger, we will pick the larynx, palpate the larynx, and then with the index finger, we will palpate the cricoid cartilage. Then we will make a vertical incision about 2 centimeters above the suprasternal notch.
And above, right up to?
Right up to the cricoid cartilage.
Cricoid, right up to. So cricoid to suprasternal. So a vertical midline incision. Yes,
Yes, sir.
yes, yes. Go on.
Then we will incise the platysma in the same line and then raise the flap, deep fascia in the same line
So
incise.
in the midline, are you expecting the presence of platysma?
Sir, you will not get that, sir. It will come with skin only.
That is my accent in midline.
Go on, go on.
Sir, then we
So
will separate the
now there will be
shaft
bleeding.
muscle.
Now you will be expecting bleeding in this situation. Bleeding is somewhat more in comparison to a normal person. Why there would be more bleeding expected? Because there might be facial congestion. Patient is struggling for air, oxygen. So there might be some congestions in the neck and face. So bleeding is somewhat more expected in this situation. But would you try to control bleeding in this situation?
Because it is an emergency setting, we will quickly place the tube between the tracheal.
So you need a quick access. Don't bothering for the bleeding. So your two fingers on either side over the skin that might control some bleeding. Okay.
Yes,
So now you are reaching right up to the.
we will separate the strap muscles with hook, blunt hook,
Yes.
and then we'll hold the cricoid cartilage with trachea steady, making it immobile. Then we'll incise between the second and third cartilage of tracheal ring. And
but what about the thyroid isthmus?
Yes, thyroid.
We'll separate it superiorly.
So sometimes you may not have to do seeking the lower border of the thyroid isthmus, trying to elevate the thyroid isthmus in an emergency setup because you need to have a quick access to the trachea.
Yes,
so sometimes you may even directly cut the isthmus over it.
Yes, sir.
So that you are gaining a very quick access to the upper tracheal rings. Right? Okay. Then so you are reached right up to the without elevating the isthmus. You are simply going through the thyroid isthmus. You are simply cutting through the thyroid isthmus. If possible, you are clipping it or you are suturing it, and then you have got a direct access to the upper tracheal rings. Then what would you do?
We incise the trachea between second and third cartilage. We'll use a tracheal dilator to dilate that and then place
you are you are now putting an incision into the tracheal cartilages. Yes. Okay, thank. Yes. So beyond the second tracheal ring, na?
Yes, sir.
So why you are putting the first tracheal cartilage and the second, and so also the second tracheal cartilage?
Yes,
why you are not starting from the first tracheal cartilage? Or sometimes possibly the second tracheal. You are preserving these, at least the first tracheal cartilage. Why so?
So to prevent injury to laryngeal nerve, recurrent laryngeal nerve and anterior jugular vein.
No. The more, basically the more you go high up, there is more chance of subglottic stenosis post-operative period. So to prevent the subglottic stenosis, laryngeal stenosis rather, you are rather not incising the first two tracheal cartilages, rather below the level of second tracheal cartilage. So you are putting now a vertical incision. Okay. Yes. Then yes, tracheotomy is done. Yes, you are now inside the trachea with your knife blade. Then the next step.
Place the tracheostomy tube. If we find blood, then we can suction it out if the time is there, and then we'll close the deep fascia and skin and then with the tape attached with the tracheostomy outer tube, we'll fix around the neck.
So you are now using a tracheal dilator. You are and you are now putting a tracheostomy tube. Okay. Yes, you are now putting a tracheostomy tube. Now, would you like to put some sutures on either side of the trachea so that the tracheal margins do not become approximated traction sutures to the lateral wall of the trachea?
Yes, sir.
Sometimes in emergency setup that may not be required. Okay. Okay. So now we are putting the tracheostomy tube. Regarding the tracheostomy tube, we will come later on. Okay. So yes, then what will be you have already got access to the through the tracheostomy tube. Then what will you do? Next step.
Then we'll fix the tube with tape around the neck. We'll close the deep fascia and skin over the tracheostomy tube, and then
what will be the position of the neck now? Extended, or it will be normal supine now before tying into the neck?
Normal supine.
Why?
We'll remove if we place the tube in the extended position,
then while the patient is made normal supine,
to hold the tube in place,
that might be loosened.
Yes, sir.
That the tying maybe loose whenever you make the patient supine. So that there will be a chance of decannulation. So make the patient in supine posture, and then you tie the tape behind the neck. Okay. So then, so this is about the emergency tracheostomy. Okay.
Yes.
So the next thing is going on to planned tracheostomy. That is, you are suspecting an impending obstruction, or you may need to take care of the airway, lower respiratory airway. You are proceeding for a planned tracheostomy. How will you do that?
So we'll go through the same procedure
Now coming on to the incisions, coming on to the transverse incision.
Incision.
So can you tell me what is the problem with the transverse incision?
So in case of transverse incision, we will come across the anterior jugular vein.
Very good, very good. Anterior jugular veins.
Yes, sir.
Yes.
So that will get damaged in emergency settings. That's why we prefer.
That's why you are avoiding. That's why you are avoiding a transverse incision in the emergency setting. Okay, but the transverse incision, you have now time to explore, so you can now proceed through the transverse skin incision because you have enough time to explore, and that is going to give a good result in terms of skin scar. Okay. Yes, and then go on. You have put an incision through transverse incision through the skin crease.
Yes, sir. Midway between cricoid cartilage and suprasternal notch.
Fine, fine. Then proceed. Next comes the platysma.
Yes, sir. Then we will dissect the platysma and the deep cervical fascia. And the deep cervical fascia will be incised. We'll place 3 hooks on the strap muscles at 5 o'clock, 7 o'clock, and 11 o'clock. Then we'll lift the thyroid isthmus superiorly.
So so you need to identify the inferior border of the thyroid isthmus. You will lift up the thyroid isthmus from the underlying trachea, and then
you hold
so
the
you are not cutting the thyroid isthmus, but you are simply lifting up the thyroid isthmus. Is it? Oh.
Then we'll fix the trachea to make it immobilized, and then incise between the second and third cartilage. tracheal ring, and then we'll
So
with the tracheal
that would be
dilator.
would that be a vertical incision or transverse incision?
That will be a vertical incision.
That will be a vertical. Now here you can put a traction suture on either side, lateral
Yes,
walls of the trachea, na?
yes,
So that you can have a luminal axis, clear identification of the luminal axis. So yes, so that you can put a vertical incision, but sometimes can we proceed for some flap consideration? Flap
yes,
consideration.
yes, sir. But I have not
What is
seen that.
Zork? I think that is named after Zork. Bzjork. So here, what you are doing, you are below the second tracheal cartilage, you are putting a transverse incision. And from the two lateral angles of this incision, you are putting further an inferolateral incision so that a lower flap of the trachea is produced. So firstly, a transverse incision below the second tracheal ring, and from the lateral angles of this transverse incision, you are putting an inferolateral extension so that a lower tracheal flap is produced, and this lower tracheal flap is sutured to the inferior skin incision so that the flap is, so this is a proper tracheostomy. This is also proper tracheostomy because you are fixing, maturing this stoma. So this is what is known as the jaw. So what is the advantage of doing this flap surgery?
So we can tissue loss is less.
Yes, the advantage is that sometimes if you do not do this, if there is an accidental decannulation of the tracheostomy tube early in the post-operative period, whenever the fistula is not already set up early in the post-operative period, there can be some immediate difficulty in reinserting the tracheostomy tube because you may not have proper identification of the tracheal lumen. But if you do this flap surgery, the tracheal lumen is already fixed towards the skin. So you will have no difficulty in insertion of the tracheostomy cannula, isn't it?
Yes, sir.
So that is the advantage. That is the advantage of doing this flap surgery. Or sometimes that you are putting a vertical incision, so also you can suture the lateral edges of the incision towards the skin, so that will be also a mature stoma, tracheostomy, that we have discussed earlier, so that the tracheal lumen will remain fixed with the skin, so that there will be no difficulty in insertion of the tracheostomy tube in case of an early accidental decannulation. Done? So that is about the flap surgery, and that is about what is known as the elective procedure, elective tracheostomy. And next comes the third situation. That is what is the percutaneous dilatational tracheostomy. Do you have any idea regarding percutaneous dilatational tracheostomy?
So through the guide wire, we do about with a 4 mm incision.
Yes. Needle. So needle insertion of 22 gauge or something like that, through which you are inserting a guide wire. Then next you are taking you are proceeding for dilatation. Already there is endotracheal tube, say along with a light source, so that you can visualize the interior of the trachea.
Yes.
Okay. Now through the guide wire, you are now inserting a tracheostomy tube. tracheostomy, but after dilatation, you are now inserting the tracheostomy tube. Light is inside the tracheal lumen so that you can proceed freely within the tracheal lumen, and you are now taking out the dilators, so also the guide wire. So this is gaining popularity in ITU setup. What is the advantage of doing this?
So small scars, less bleeding. We can visualize the procedure through the camera, so less chances of complications.
Monitoring. Yes. And the basic advantage is this, that for a planned tracheostomy, the ITU patients, they are not needed to take them to the operation theater,
Yes, sir.
or you don't have to make ready the operation theater, bedside operation theater. So these are the basic advantage, and it is a minimally invasive procedure.
Yes.
Dr. Shaha, would you start something at this point? Hello. Okay. Hello, Dr. Aditi.
Yes, sir.
Hello. So we have done the 3 different types of tracheostomy. Next, we will be considering the say post-operative follow-up after doing a tracheostomy. So post-operative follow-up. So the patient is now in his or her bed. What are the things that you will keep ready by the side of the bed of the patient?
Similar size tracheostomy tube.
So another new tracheostomy tube. Okay, done.
Oxygen.
Oxygen, yes.
Then all the instruments that might be required for an emergency tracheostomy in case it gets
So
decannulated.
retractors and tracheal dilators.
Yes, sir.
Huh?
Yes, sir.
Retractors and tracheal dilators. Okay. Sterile gauge piece. Okay.
Yes, sir.
And always there should be a vigilant nurse. Huh?
Yes, sir.
There should be a vigilant. And so also you have not mentioned about the suction. A suction tube and a suction apparatus.
Yes, sir.
Okay. Or a central suction. Availability of a central suction. So these things should be kept ready bedside. Done. Done. So the next thing is now we have done a tracheostomy. So what are the physiological advantages that you get after doing a tracheostomy? Physiological advantages. Hello.
Yes, sir. Physiological advantages.
So that is the dead space that is
The dead space will
minimized.
decrease. Yes, sir.
Yes, dead space will decrease, and that's why the effort is much less needed on the part of the patient to take air inside, so that the ventilation will get improved. And another point is that by securing the air passage through a tracheostomy, the patient can take food, which was not possible when the patient was on laryngotracheal intubation, isn't it?
Yes, sir.
So basically, these are the advantages. Now, doing a tracheostomy, after doing the tracheostomy, what are the physiological disadvantages?
Patient becomes dependent over the tracheostomy tube for use for longer periods.
Right. Before that, you are obviating the natural air passage, that is the upper respiratory tract.
Yes.
So the air is losing heat as well as the humidification of air that is lost. So you are losing temperature, humidification. And if a prolonged tracheostomy is continued,
Yes, sir.
What will be the changes in the tracheal mucosal epithelium? There will be change in the cilia. Because tracheal mucosal epithelium contains cilia that characteristically produces some movement so that the sputum goes up. So the cilia are lost. So ciliomucosal movement would be lost. Yes, yes. And there the mucus would be viscid, thick, and that can produce an incrustation around the tracheostomy tube.
Will get blocked.
So these are the physiological disadvantages. Na? These are the physiological disadvantages. Okay. So next, so we have already come towards the end of these things. So next, can we pass on to the complications? Complications of doing a tracheostomy.
The immediate complications could be injury
Now,
to
first,
the local.
what can be the part-operative problem?
Immediate injury to the local structures like thyroid cartilage, mucoid cartilage, recurrent laryngeal nerve,
So
anterior vein.
damage to the trachea, damage to the larynx. Yes.
Yes.
Then, if your incision, suppose the patient is an obese lady with the thick panniculus of fat, you may not even identify the trachea in the midline. You may have to, you can go towards the lateral edges accidentally of the trachea so that you can injure the other vital structures. That means you can injure the esophagus.
Yes, sir. That posteriorly esophagus.
Carotid artery, badly done. Okay, so injury to the carotid artery even. And there can be bleeding, profuse bleeding now while doing the tracheostomy. This is the part-operative problems.
Yes,
so gross injury to the trachea, injury to the esophagus, injury to the recurrent laryngeal nerves, and injury even to the carotid artery with profuse hemorrhage. So these are the part-operative problems. Okay. Now coming on to the immediate post-operative situation. What can be the problem?
Tube decannulation, then subcutaneous emphysema around the.
Yes. So accidental tube decannulation. Okay. So that is really a problem in the early postoperative period. Particularly, suppose the patient is still restless, violently coughing. So there can be an accidental dislodgement of the tracheostomy tube. This is really a very troublesome problem on the part of the surgeon because he has to reinsert the tracheostomy tube. Okay. So this is what. Go on with the other early complications.
Subcutaneous emphysema around the skin area. Then there can be
subcutaneous emphysema. Yes.
Then there can be skin necrosis around the tube.
Yes.
Then there can be pneumothorax.
Yes, pneumothorax. Can you tell us what can be the cause of the pneumothorax?
So injury if we injure the trachea in the thyroid tube.
Not trachea, because on the lateral sides of the trachea, the apical lobe of the lung along with the pleural cover comes up. So accidentally the pleura can get injured, leading to pneumothorax. Yes. Anything else? Pneumothorax. Subcutaneous emphysema. Infection of the trachea itself. Gross tracheitis. Anything else? Pneumomediastinum can also be pneumomediastinum. What can be the cause of subcutaneous emphysema?
The air trapped between skin layers.
So air, so sometimes you have done a false passage, okay? So
Yes, sir.
in the subcutaneous, so you have, so the air can escape from the trachea and not coming out through the tracheostomy tube, but reaching into the subcutaneous space and can spread throughout. Okay, that can be the cause of subcutaneous emphysema. So tracheitis, and there can be a spell of apnea as well.
Yes.
So can you tell why can there be apnea sometimes?
So
Because
it's
carbon
get
dioxide is washed out, na? Yeah. Just after relieving the obstruction, the patient has now free, hurried respiration, and that can lead to washing off of the carbon dioxide, and there can be a spell of apnea as well. So next, come on to the important late complications. Important late complications.
tracheostenosis
Hello.
or tracheostenosis,
See, tracheal stenosis. Yes, yes, tracheal stenosis.
then tracheocutaneous fistula can form.
Tracheocutaneous fistula. What is that? Tracheocutaneous fistula. What is that?
So the
What is
fistula
the
with
cause? What is?
external opening due to the continuous tube.
Yes.
The granulation tissue develops between the trachea and the skin surface, and
So the
making a
tracheal epithelium,
fistula.
mucosal epithelium also grows towards the skin, right up
Skin
to the
surface.
skin. So
Yes, sir.
continuation of the epithelial skin surface right up to the skin and produces a tracheocutaneous fistula.
Yes.
Any other important fistulization?
Tracheoesophageal fistula.
Tracheoesophageal fistula. What is the cause of that?
Maybe due to infection or false passage during the tracheostomy.
The more common reason is that the tube that is inside the trachea, the end of the tube may come in contact with the posterior wall of the trachea, and chronic friction can lead to necrosis of the posterior wall of the trachea, leading to a communication with the esophagus. So tracheoesophageal fistula. Then any other fistulization, a dreadful complication. If the fistulization occurs through the anterior wall of the trachea,
Anterior wall.
tracheoinnominate artery fistula, because just at the anterior wall of the trachea in the superior mediastinum, there is the innominate artery. So similarly, the pressure necrosis through the end of the tracheostomy tube can lead to an accidental fistulization with the innominate artery, leading to profuse hemorrhage. Profuse hemorrhage. So this is the dreadful complication, tracheoinnominate artery fistula. So these are the three different fistulization: tracheocutaneous fistula, tracheoesophageal fistula, and tracheoinnominate artery fistula, a dreadful complication. And one more complication is tracheomalacia. Tracheomalacia, isn't it? So these basically these are the complications related to tracheostomy in three different phases: perioperative complications, immediate postoperative complications, and the late complications. And already we are towards the end. Coming on to the tracheostomy tube, what are the different parts of the tracheostomy tube?
So we have an inner and a outer tube. In case of a Fuller's bivalve metallic tube, tracheostomy tube. Then other type is it could be a disposable tube which can be cuffed or uncuffed.
So initially, while inserting the tracheostomy tube, during the procedure, we insert a cuffed tracheostomy tube or a non-cuffed tracheostomy tube.
So we start with cuffed tracheostomy tube.
So we inflate the cuff. we
Yes, sir.
inflate the cuff.
Inflate.
Okay.
Yes, sir.
So do we continue with the cuff tracheostomy tube for a prolonged indefinite period?
No, sir. That might cause pressure necrosis, so that's why we shift to
Yes.
uncuffed tracheostomy tube.
So gradually we deflate the tracheo. Yes. So and finally we do consider a non-cuffed tracheostomy tube.
Yes, sir.
Non-cuffed tracheostomy tube insertion. Okay. And finally, two or three important points regarding the tracheostomy tube care.
Sir, we have to maintain complete asepsis around the tracheostomy tube, and we have to do regular syringing, regular suction of the tube, and then we have to ask the patient for regular chest physiotherapy, and then if we have given
chest physiotherapy particularly, na? Chest
Yes, sir.
physiotherapy is also to be done. Okay.
Yes, and if we have given a metallic tube in an emergency setup, then we have to shift to a tough rubber tube in within 24 to 48 hours.
Acha. So already we have come towards the end. Anything left? So Dr. Shaha, are you here? Dr. Shaha? Hello. Probably Dr. Shaha is not here. Dr. Aditi?
Yes, sir.
So already we have completed the different aspects of tracheostomy. So probably we can end it up here. Okay, isn't it? So thanks to Dr. Aditi and thanks to the listeners. Thank you very much. Okay.
Thank you, sir.
Okay.